started. My name is Miller Piggott, and welcome to Alzheimer's of Central Alabama's Alzheimer's Disease Update. We are so pleased to be able to have Marissa Natelson Love with us here today. This is actually an encore performance. She gave this talk for us at the Vestavia Library, and it was so well received. I asked if she would mind repeating that, and so thank you for your generosity with your time, especially. Dr. Natelson Love is an Associate Professor of Neurology and part of UAB's Alzheimer's Disease Research Center. She has 10 years experience in clinical care and research programs for people with dementia and related disorders. And I understand we're catching you on an exciting day in the world of Alzheimer's research. And so give us an update and fill us in on what all that means.
Absolutely. You want me to just go ahead and get to that with the talk? Okay.
Yeah.
Absolutely. I'm happy to be here. There's a lot to talk about. It is very exciting what's happening in Alzheimer's disease. I will dive right in. All right. So what my objectives are for you as the learner is that by the end of this session, that you will have an understanding about Alzheimer's disease, including what we're calling asymptomatic Alzheimer's and some of the atypical presentations of Alzheimer's disease. I want you to also be introduced to the developing anti-amyloid therapy medications in Alzheimer's disease. So I'll get to that in detail as we move along. I wanted to disclose that I am an investigator working with several different industry companies. Biogen, Eisai, Eli Lilly, and Janssen all, have studies at UAB that I'm a sub-investigator on. So here's our definitions. The word dementia, I start almost every clinic visit with this. Sorry about that. I'm trying to make this little bar at the top go away so I can see my whole slide, but I think I know what it says. Dementia is, and now a lot of people ask me a lot of questions about this word because it feels very negative. There was actually a period of time where all mental health diagnoses under which this was listed led to people getting put in, locked up in mental hospitals, involuntarily, and that's not the case. So all that dementia means by definition is that someone has cognitive deficits that will limit that person's ability to perform their activities of daily function. So someone else has to do those things because they need to do that to keep that person safe is what qualifies as dementia. So it's just a description of their symptoms. Mild cognitive impairment is when somebody has those cognitive deficits, but they are still independent. So those are some stages that we talk about and are just a description of the symptoms that someone's dealing with. So then frequently people will say, well, then what's the difference between Alzheimer's and dementia? So Alzheimer's is the most common type of dementia, dementia being anything that can cause you to have those declines. And then Alzheimer's being the most common form, and it affecting 60 to 80% of people that have dementia. So that is why people often, when they're talking about dementia, they're probably talking about Alzheimer's, but it's not necessarily always true. The second most common cause of dementia is vascular changes in the brain, and oftentimes those coexist with Alzheimer's disease. And then we talk about things that are less common, like dementia with Lewy bodies or frontotemporal dementia. But Alzheimer's and we say related dementias, Alzheimer's is the most common form. So that's the difference between Alzheimer's and dementia. Now, this is the Alzheimer's Association facts and figure infographic that I'm showing you that talks about how Alzheimer's disease affects America. And at risk of being sort of tedious, I'm going to read you what it says because it's just so staggering. It is currently affecting more than 6 million Americans. Over 11 million Americans are providing unpaid care for people that have Alzheimer's or related dementias, and the unpaid care would value nearly $340 billion. 1 in 3 seniors dies with Alzheimer's, whether or not it is called the primary cause of their deaths. they have Alzheimer's or another form of dementia, and it kills more people than breast cancer and prostate cancer combined. So our lifetime risk for somebody who is 45 years old is 1 in 5 for having Alzheimer's in women and 1 in 10 in men. So that means, over the course of your entire lifetime, not onset at age 45. Between 2000 and 2019, deaths from heart disease decreased, while deaths from Alzheimer's disease increased exponentially compared to the decrease in heart disease. As we're doing a better job, treating some of these vascular risk factors, people are living longer, and that length of time increases risk of Alzheimer's disease. In 2023, Alzheimer's and other dementias will cost the nation $345 billion. And that's not including all that unpaid care we talked about. And by 2050, these costs could rise to $1 trillion. So a lot of people do not talk to their doctor right away when they're having these symptoms, but most people would want to know, especially if there were treatment, which is something that we should talk about today. Alzheimer's in Alabama, I won't read you everything on this slide, but is increasing 14.6% between 2020 and 2025. There are not enough people in the workforce helping with this, which is a great need. And the number of deaths from Alzheimer's disease increased between 2000 and 2019 by 197.1%. So it is right here at our doorstep. So the symptoms or warning signs of Alzheimer's disease. So certainly everybody, when we forget, where we put something down, has a moment. I do, because this is what I do all day, going, is there something wrong with me? Well, memory loss that impairs your daily function. So something, forgetting something important that would actually lead to you not being able to do what you need to get done during the day is the type of memory loss that we're talking about. Challenges in planning or problem solving. I like to ask folks, like, could this person pack for a trip successfully, as an example of planning or problem solving. Difficulty completing some familiar tasks they've done before. Confusion with time or place. Trouble with visual images, maybe not recognizing people or places. New problems with language, misplacing things that they can't retrace their steps to find. Poor judgment, getting duped by, people. There's lots of us who have to be very careful about getting duped by people trying to gather information on the internet or phone calls, but something that you think, is beyond what they would have done previously, making judgment calls. Withdrawal from their usual activities or changes in mood or personality. What we see in the clinic, and what we will call it, is amnesia. So if the person went to the store yesterday, would they remember that they went at all? It's, could be normal to be distracted and forget something you went for, but the fact that someone doesn't remember that they went at all is true amnesia for the event. Anomia is a problem finding words or naming objects. A lot of people have trouble finding words, but anomia typically goes, beyond the typical, it just took me a few more minutes to find the word I really wanted. Visual deficits, we will test somebody by having them copy a figure. Poor orientation. Now, somebody does have to have both short-term memory and the ability to pay attention to know what date it is. And that's not always the case for a lot of us. Poor abstraction. We ask people what's the similarity between items and try to gauge how well they can sort of apply that to their semantic knowledge or their general memory. Semantic deficits is, again, disorganized categories of objects, the ability to remember what belongs in a category. If I said, what are some articles of clothing or what are some animals, remembering what belongs in that category is something that is lost in Alzheimer's disease. And typically, social behavior is better than the cognitive abilities. So that's a real risk factor for these folks going unnoticed, because you get a 15-minute appointment with your primary care doctor and you seem just fine. They're not asking you any difficult questions, to test your cognition. That person might, go below the radar. And that's why we need we need some input from family, and we need some ways to screen people. So Alzheimer's disease. This is what we know about Alzheimer's disease and how it develops over time. This curve have been referred to as the Jack curves because they were published by Clifford Jack in 2010. And they were developed by looking at studies with folks that have dominantly inherited or dominant genes with that lead to Alzheimer's disease. So we were able to follow people for many, many years before they have symptoms and know that this happens. And then later on, we were able to do that with people without that genetic predisposition. So I'll walk you through this. The red line here is a buildup of a toxic plaque in the brain called amyloid beta. And that can build up to 20 years before somebody develops symptoms. This dotted line here that you see is the beginning of symptoms being developed, and that's the mild cognitive impairment. So you can see there's a long period of buildup of amyloid plaque before somebody has symptoms. The next thing that we notice happens in the natural history of the disease is that the communication between nerve cells becomes dysfunctional. Synapses are the spaces between the nerves. So synaptic dysfunction is problems with the communication between the nerves. And we can see that on certain types of PET scans or functional MRIs. And then as nerve cells begin to be injured, that doesn't happen initially with the amyloid buildup. Later on, something happens and there's another protein that gets activated inappropriately or gets processed inappropriately. And that leads to breakdown of the nerve cell itself. That's the green line. The green line shows you as the nerves break down, they release some of that abnormal protein into the spinal fluid, and we can measure that. That tau is the name of that abnormal protein. And then the blue line is when the brain structure actually starts changing. So someone could see that on an MRI. And then finally, the purple is when our cognitive tests will pick up changes. And of course, the function, as that declines, that leads to the dementia, and that's brown. So we're going to go through this in more detail on how we figure these things out. So if somebody begins to have cognitive decline, and we can measure that on one of our tests that we give you in clinic, we can prove that it's Alzheimer's disease a couple of ways. Biomarker evidence of the amyloid beta or evidence of the neurons being injured. I'm going to show you how we do that. So this is a brain MRI, and I'm looking at the structure. So I'm looking at this person as if I were looking straight on at them and made a slice through their temple. And this area that's outlined in reddish pink here is the memory center called the hippocampus. When there's two of them, you call them hippocampi. But that is the area that breaks down, and as it becomes smaller, we call it atrophied over here on the Alzheimer's disease side, and it opens up a space next to it. So the black you see is the space, that's spinal fluid, and that's normal. It's supposed to be there, but there's more of it that you can see when the gray, which is the brain, has broken down. And the areas next to it are other areas that we look at just related to Alzheimer's disease, other parts that you don't necessarily need to know, but it's the hippocampal atrophy, which is very specific for Alzheimer's. So I put that on the chart here, made my own chart to show you, it's not until this point that we can typically see that change on the MRI. So then the other thing we could do to see the breakdown of the neurons is measure that tau level in the spinal fluid. And I mentioned that before. So it's a special tube you have to use because the normal tubes that people collect spinal fluid in actually interfere with the test. So you have to use a very special tube. So you have to have someone that knows, a little bit about what they're doing in order to test that spinal fluid through something called a spinal tap or a lumbar puncture to gather that spinal fluid and test for them. So this is evidence of synaptic dysfunction, and this is called an FDG PET. So there's a couple different kinds of PET scans, and a PET scan is where they will take any kind of radioactive thing that will sort of light up on a scan, and they attach it to something that will basically find what we're looking for and make it light up. So in this case, FDG, the G is for glucose or sugar. The sugar is given to the person taking the test into an IV, and it's got that radioactive fluoride on it, and it lights up everywhere in the brain because the brain uses sugar as its fuel. So this is normal over here, and these sort of warm colors, the red is really active. It's using a lot of sugar. And as somebody develops problems, you'll see that it becomes kind of a cooler color as there's not as much activity. And there's a pattern to this that's very specific to Alzheimer's, where it involves these lobes here and then the temporal lobes. These are the parietal lobes. So we can do an FDG PET, and we can say, okay, this is the correct pattern. And that goes here on this orange line, sorry, above the green line, in terms of, how we can test for Alzheimer's disease. The final kind of PET that, not the final actually, but the next PET I'm going to talk about is amyloid PET. So similar to the glucose, but that active radioactive nucleotide is attached to something that will bind to amyloid plaque. So it's going to find those toxic brain plaques and make them light up. So this is a negative scan, and this is a positive scan. So showing you that this person has built some buildup, and then as the disease progresses, you actually notice their hippocampus is getting a little smaller, and they have even more plaque buildup on the edges, on the cortex of their brain. And that is something that is critical to when we're going to talk about these new drugs that are coming out. So that's there on the red line. So those are all the tests we can do to look for those things in terms of things that we do outside of the clinic visit itself. So there is something called preclinical Alzheimer's disease, or asymptomatic Alzheimer's has been the way we've been talking about it more recently. And it's really a research diagnosis. We're not doing this in clinic because it's not something that we know intervening on will help, but we're trying to do that in research. So this is folks who have had either spinal fluid tested or an amyloid PET to look for those amyloid plaques and tangles, or they have an autosomal dominant Alzheimer's disease mutation, like the folks that I mentioned earlier. And most recently, there are actually some blood tests for amyloid and tau that are not available in clinic, but we have found we can use in research to identify who, may be at risk of later on developing Alzheimer's disease, symptomatic Alzheimer's disease. So we've done some research using these drugs that actually remove that toxic plaque from the brain in order to prevent these folks from ever getting Alzheimer's disease. So this one called A4, we just got results back on. It was using a drug that actually failed in people that had symptomatic Alzheimer's disease. And it also failed in people that had asymptomatic Alzheimer's disease, unfortunately. It didn't seem like it really effectively actually removed the amyloid plaque from the brain. And so that was a big disappointment, because these folks had been in the study for 8 years, receiving monthly infusions of a drug, or the placebo. Everybody ended up on the drug eventually, but to find out that it didn't make a significant difference was really disappointing. But we have a new study called AHEAD, and AHEAD is sort of the next generation of that. AHEAD is using a drug that has had positive effects in people with symptomatic Alzheimer's disease. It's the drug lecanemab that got accelerated approval back in January because it was effective at removing amyloid plaque and keeping people more independent for longer. And so we're using that drug now in a study that we're recruiting for called the AHEAD study. And that's for people who are asymptomatic. So no complaints. We also have a study for folks that have that autosomal dominant mutation to try different things in them. And then there's a registry, which is called TrackPrad. basically, where we're getting people in and then sort of having them queued up if they want to be in a study in the future. So what does anti-amyloid therapy do? It's where we give somebody an antibody that was synthetically made. Antibodies are just like the things that fight off infection in your body, in your immune system. And they can either attack the amyloid plaque directly, like here. And I tried to try to use the spotlight, but I'm not sure if that works or not. That's the amyloid plaque here. And the amyloid plaque, can then be broken up and taken away, or those antibodies can help the rest of the immune system, like here in the middle, find the amyloid plaques and tag them so the other parts of the immune system can absorb them or break them down. Or it can actually remove the amyloid that's in the bloodstream. And because there is a gradient, there's more in the brain, in the spinal fluid than there is in the blood, it actually can pull some of that out of the spinal fluid so that there's less to build up plaque. Those are some ways that works. So the sordid history of the anti-amyloid drugs in the United States in the last couple of years. I will start with aducanumab. It's a controversial drug because they actually, well, let me tell you that it got accelerated approval June 2021. Accelerated approval is a mechanism that the Food and Drug Administration came up with during the HIV epidemic, because we had problems with getting drugs to people with HIV before they died, because the FDA was originally made to protect us from all the snake oil that was out there. And so it was very stringent and took many years to get things approved. So basically, based on some kind of biomarker, not necessarily proof that it kept people alive longer, they were able to approve drugs. So in this case, they were able to approve aducanumab because they proved that it actually lowered the amyloid in people's brains, but didn't prove that it actually made a difference for those people, like kept them more independent for longer. So they came out, they said it was had accelerated approval, and the drug company listed it at $56,000 a year, which would absolutely bankrupt Medicare. So the Medicare actually, it was controversial as well because everybody on the advisory committee to the FDA voted against approving it. And then it got approved anyway. So there's just something that it required investigation at one point, something wrong with how that went down. The side effects of the drug were that, I'm trying to get this thing to go away. That blue thing. I don't know how to use this apparently. There you go. I got it. So the side effects of the drug. ARIA is short for amyloid-related imaging abnormalities. ARIA are the main side effect of this drug, or other than an infusion reaction where somebody, as they get something put into an IV, gets elevated blood pressure or feels short of breath or has an allergic reaction. So there are two forms of ARIA: swelling or edema, or bleeding or hemorrhage. And so people on all of these drugs have to be monitored with MRIs to look for any of these abnormalities related to the drug. And if people have symptoms, then the drug has to be stopped. It's more common in people that have a certain gene called ApoE4. And so that's something that we've started testing in people that are going to be on these drugs to give them an idea of their risk. Everybody has ApoE genes, but there's two copies of each gene, and you have three options, 2, 3, or 4 for what you've inherited. You get one from your mom and one from your dad. And the E4, if you get one copy, you increase your risk by doubling it of having these side effects. And if you get 2 copies, it's up to 6 times more likely that you'll have these side effects. So that's why we started checking it in everybody, so they had an idea before going into taking the medication. So 35% of people on aducanumab had some kind of ARIA. but 74% of those people had no symptoms. So they thought it was worthwhile. And we just need to monitor with all these MRIs. This is the course at the bottom of how many MRIs that people got for aducanumab. So what does ARIA look like on a brain scan? Well, here's swelling. This white stuff in the gray is swelling in the brain. What it might give somebody is perhaps a headache, more confusion. It could actually, if it's really bad, lead to a seizure. Those are the typical symptoms. This is a little bit of inflammation around the edge of the brain. That's the swelling. This is a little bit of bleeding, as is this, just showing you two different types of the type of bleeding that you see. Now, those little hemorrhages are not going to bother anybody. They're not symptomatic, but we watch them anyway because it just says that there's a leak somewhere. And if you have too many in one spot, that predicts that you might have a big bleed, and that would actually be very dangerous. So that's something that we monitor. So what about this drug lecanemab? So lecanemab, or the brand name Leqembi, it got the accelerated approval in January of 2023. And based on the same thing, it removes amyloid from the brain. But this, in this case, they actually finished the study. They didn't finish the study with aducanumab. They stopped it early because they didn't think it was working. They finished the study of lecanemab, and they proved that it actually does keep people more independent for longer. So this is a measure of how independence, basically, how somebody is doing in their daily activities. And there was a significant difference between the people on drug in the yellow and people that were on a placebo in blue. And then this chart shows you that it actually removes the amyloid from the brain, and the placebo stayed stable. And this is a cognitive test that they were given. And actually, these people are doing better after 18 months on the cognitive test than people on placebo. So what they said was it was a 27% slowing down of the worsening. So people still got worse, but almost a third slower than people not on the drug. So here's the list of people who got side effects, just like we talked about with aducanumab. And I circled the number of ARIA is, about a third as that with aducanumab, 12.6%. So it does have a lower risk. This particular drug is given every 2 weeks instead of once a month. So it is a little bit more of a time commitment. So is Medicare going to pay for it? Medicare decided after that aducanumab that it wasn't going to pay for anything that only had accelerated approval, unless that, like Biogen, the company that made aducanumab, created a new clinical trial that people were in, and they had to be, followed very rigorously, and it had to meet certain criteria that Biogen didn't really feel was worth the money to design and do. So that hasn't happened. On June 1st, CMS actually said, that's Center for Medicare Services, that they would cover folks on one of these drugs if they're in a registry. So we have a registry that was created by the Alzheimer's Association to put these folks in. So we're just kind of following them over time to see what kind of side effects they have. And the drug was submitted for full approval, and the decision is due today. So I've been watching my phone to see if I get any kind of notifications about whether or not it gets approved. There was a committee, the advisory committee met last month and unanimously recommended to approve it. So there is a lot that's going to change very soon. Then we will hear about, how much it costs and all the other details about payment after we get the decision today. There is a third drug on the horizon called donanemab, and it was submitted to the FDA in May. And that also has positive effects. So stay tuned for that. It's only once a month. And in their study, they were able to stop drug after sometimes about a year because people didn't have any amyloid anymore, whereas there's no real end date that was done in these other trials. So it may be an interesting option to add. So, a lot about typical Alzheimer's disease, and Because we have all these new treatments on the horizon, I want to make sure you're aware of the atypical presentations of Alzheimer's disease. It's not always the memory type of Alzheimer's disease, although that is the most common. First, I'm going to address the difference between early onset Alzheimer's disease and late onset. People sometimes use the word early onset and they mean early stage of disease, even in somebody that's older. But what it really means is somebody who develops symptoms before they turn 65 years old. So only 5% of those 6 million Americans with Alzheimer's disease have early onset Alzheimer's. There is an association with those 3 autosomal dominant mutations I mentioned before. They're called presenilin 1, PSEN is the abbreviation, presenilin 2, and amyloid precursor protein. The onset age in those genetic mutations is actually typically, before age 50. So there is a lot of people that have early onset Alzheimer's disease that do not have those mutations. And the difference being, in whether or not they pass those on to their children. If they don't have one of those autosomal dominant mutations, then their children aren't necessarily at risk of having the disease. Late onset Alzheimer's disease is 65 and older, and there is an increased risk in people that have that ApoE4 gene variant that I mentioned earlier. If you have one copy, you're 3 times as likely to get Alzheimer's disease actually than someone who doesn't. And then it's about 10 times as likely if you have 2 copies than somebody who doesn't, but it doesn't, directly cause Alzheimer's disease. It just increases the risk. So typical Alzheimer's disease affects the areas in orange. So, and this is, Dr. Geldmacher made this originally, and I've borrowed it just to show you, what the functions are that are done in those parts of the brain. And that's why people with typical Alzheimer's disease have problems with memory, language, visual processing, and behavior. So this is the last PET scan I'm going to show you. There's actually a tau PET scan that looks for the buildup of that abnormal protein. And it's been FDA approved for many years, but it, again, is not paid for by Medicare. So we don't do them in clinic, but we do them in research. And it shows you that those areas that were highlighted in orange on the last slide are where the tau buildup is. So, that's where the nerves are breaking down, and that's what leads to symptoms. So, I believe this at the top says demographics of the atypical Alzheimer's disease. I can't see it, but so the prevalence is 15 to 65 per 100,000 in people that are ages 45 to 64. So it's not that common, but 1/3 of all the people who have atypical Alzheimer's disease have young onset, meaning they're younger than 65. So it disproportionately affects younger people. And, that may be something to look out for in somebody, who you don't think is old enough to have Alzheimer's disease. They may have one of these atypical Alzheimer's disease. Only 6% of people with atypical Alzheimer's disease, or 6% of people that have late onset Alzheimer's disease have an atypical presentation. You're more likely to have a memory dominant problem if you're over 65. So here are the types, and I'm just going to breeze through them because, I just want to give you a general idea that they exist. You don't need to know everything, I know, because it's not as common. Logopenic variant, frontal variant, posterior cortical atrophy, and then the corticobasal degeneration syndrome. So let me go into detail about that. So they're called hippocampal sparing Alzheimer's disease. Whereas typical Alzheimer's disease, like I mentioned earlier, affects the hippocampus, which is your memory centers. I wanted to show you this. The blue is the higher level of tangles, and in the hippocampal sparing disease, you have some tangles in the green as well, because it's mixed with sort of what's the normal yellow here. That you have some tangles in the frontal lobes, and the language area here, or back in the vision areas. This is the actual tangle under a microscope, and some plaques, some amyloid plaques. So that tau PET that we can do lines up with the FDG PET that does get covered by insurance. So we often actually test for this with an FDG PET in our clinic. So the areas where the nerves are not communicating to each other on that FDG PET are the same where the tau builds up. And that's what this is showing us in each little subtype of the atypical Alzheimer's disease. So I think we must have some language variant up here. I can't see that top for whatever reason. Visual area, executive, motor, and behavioral, depending on which atypical variant we have. So let me get you a little bit more information about logopenic primary progressive aphasia. It's a huge word. Logopenic is, logo is few and penic is words in Latin. So few words. And the primary problem is a language problem, hence the primary. And aphasia is language problem, and progressive meaning it's progressively worsening. You could have acute onset of a language problem or immediate onset, like with a stroke. But this is something that might look like a stroke, but it's been happening very slowly over a long period of time. People that have this type have, and now there's actually a couple other types that are not due to Alzheimer's disease where someone has primary language problems, but this type that's related to Alzheimer's disease has problems with coming up with single words, and they have difficulty repeating full sentences, but they are able to speak with normal syntax and grammar, and their motor abilities to speak are preserved. So people may pause as they're trying to find the right word, so it may seem like they're not as fluent, but they are able to be fluent at other times, whereas there's this other type of primary progressive aphasia where people can't be fluent. They can't usually use more than a couple of words at a time. So there's also the frontal dysexecutive form of atypical Alzheimer's disease. And that can look very much like behavioral variant frontotemporal dementia. So somebody may have behavior changes where they have apathy, which means lack of interest in doing things that they used to be able to do, which can look like depression on the outside. But if you ask the person, they're not sad. They just don't feel motivated to do things. Or someone who's doing something inappropriate because they're disinhibited. Or depending on which part of the frontal lobes are affected the most, they could have a problem with executive function or the organization of their thinking, and therefore not be able to do something like planning a task when someone does cognitive testing. Posterior cortical variant is the problem with vision. So it affects the back part of the brain, and the cortex is the thinking parts, the cover of the brain. And the back part of the brain is where we see vision primarily in the occipital lobe, and then we process the visual information in the lobe next to it, called the parietal lobe. And so people with this will have space or object perception difficulty. We might give them a test where we show them this, which was originally developed to look for color blindness. But if they're not colorblind, it should be that they can read the number there. And if someone's having trouble with perceiving, more complex visual features, they may be having this problem. And apraxia is a memory for how to do a particular action, despite having, the actual motor skills like strength and sensation intact, but say, the steps in order to turn on the TV with the remote control is a really common apraxia. And we might actually ask them to mime doing something like brushing their hair as a way to test for apraxia. And despite the fact they could hold a hairbrush, they don't remember the steps to do it. Reading difficulties and calculation difficulties, which is interesting. Apparently we use some of our areas in the posterior where we have vision problems, vision abilities to interpret or do calculations. Complaints, people might have trouble getting lost while driving. I had somebody who said, we live out of state half the year, and my wife doesn't drive in the mountains where we live, but when we come back to Birmingham, she no longer remembers how to get anywhere. And maybe it's just because she's out of practice, but she actually did have this posterior cortical atrophy. Difficulty with depth perception might mean they follow too close to the person in front of them. I have people that have difficulty going up and down stairs. And then someone that has difficulty calculating the tip, so that they might have problems with calculations. These people may come to you after, or you may hear about that they've had multiple eye exams and they can't find what's wrong, for example. Those may be red flags for this disease. And then the eye doctor can't figure out what's going on. And a lot of people have a lot of anxiety related to this disease. And I think some of it is actually related to neurochemical changes. And some of it is the fact that they have, symptoms that are obviously very debilitating, and they have preserved memory, that they're a problem. So that's definitely a common problem. So the last of these atypical syndromes is corticobasal degeneration syndrome. And it is a combination of the first three. So somebody with corticobasal degeneration syndrome may have problems throughout an entire hemisphere or half of the brain. So they may have problems in the front that cause the executive dysfunction. They may have problems in the language area, so they have language problems. They may have problems in the visuospatial areas, so they cannot interpret things as well. They typically also, it involves the deep areas, not just the cortex. So you get some changes to their movements, like Parkinsonism, meaning somebody who doesn't have Parkinson's disease, but may have one, arm and leg that are stiffer than the other. They don't typically have tremor. And that arm or leg may jump. That's myoclonus. And it may have alien limb. Alien limb is not like on House where the patient's arm tries to choke them. Alien limb is not your limb has its own brain. It's that your brain sort of doesn't know where that limb is in space. And so it might take a weird posture, like holding it up to the side and not realizing it. So that's the corticobasal degeneration syndrome. So that is the extent of the atypical Alzheimer's disease. I hope you guys learned a lot. I'm sure you have a lot of questions. I was reading, there's one question, I'm not sure it's what it's referring to, but we can come back to that in the Q&A. I have a slide here. I want to thank my division director, Dr. David Gelmacher, as well as my chair at UAB of Neurology, and the chair is David Standard, our Brain Age and Memory Clinic team, and of course, every one of you for paying attention. I was actually getting paged. I'm sorry if I was distracted there during the talk. And at the end here, while we have questions, I actually want to put up the last slide. There was a question when we did this at the library about how to get involved in research. So I put up a slide with a QR code that has a link that you can fill out some info that will go to the research team or the phone number. So I'm here for whatever questions you guys have.
Thank you so much. That was really great and just full of a lot of really good information. I know everybody's trying to process. I did have a question that came in earlier, and this was from one of our support group members, and she wrote, can a dementia patient suddenly decline? And she has noticed sudden decline in his ability to remember conversations that they've had, but also his functional ability in the kitchen, because that used to be his domain, and now he's really struggling with basic things.
That's a great question. So, and it comes up very frequently. The underlying process of dementia is a slow process. So when something happened suddenly, like in the course of a couple of weeks where somebody has a decline, we typically look for something else that is making their symptoms worse, like a urinary tract infection being a really common thing that you might not have other symptoms of. There could be any other illness, whether that be infection, allergies, actual, injuries like pain, problems with sleeping, or even constipation. Somebody that's been really constipated, they no longer have the ability to sort of scan and remember what's going on in their body to tell you that that's happening. And that may be something that you have to keep track of in order to see if that's a reason. So generally we'll say, go to your primary care physician, make sure they check the urine and do a check and follow some of those other things. If all else fails, I usually say, give them a Tylenol and see if they seem any better. If they can't tell you they're hurting and they might be hurting, that might be something, if we can't find anything else to try. Sometimes it's just a new environment. You go on a trip and that person has been taken out of the routine that kept them they're able to do, certain functions. But if you go in a trip and they're out of their routine, they may not have the ability to compensate anymore. And so you see some worsening in that case when it's a psychological stressor rather than a physical stressor.
Okay. Well, if anybody else has got a question, please put that either in the chat or in the Q&A at the bottom of your screen. And if you don't mind, I'll take just a minute to say a few words about Alzheimer's of Central Alabama. There were a lot of new friends that were on with us today, as well as old friends. So I'm not sure everybody knows who and what our organization is, but we're a local nonprofit that provides services for families. Our primary services are to help families that are struggling to care for a loved one at home, like scholarships for adult daycare, continence supplies, insure, and we also manage the Project Lifesaver bracelet to help keep people who are at risk for wandering safe. We've got two big things coming up this month. One is our Glow for a Cure golf tournament. That's a nighttime golf tournament. It's July 28th at the Highland Golf Course. And you'll just need to get in touch with us if you're interested in that. I think we're about at the limit of how many teams we could have. But along with that, we'll be having a raffle for a $1,000 Amazon gift card. So that is a lot of fun. And both of these events help raise money for our predoctoral scholars in Alzheimer's disease research at UAB. So I hope y'all will consider supporting those, as well as our local walk. Our local walk is always the first Saturday in November. So this year it's November 4th. So we did have another question come up, and it says, at what stage is the patient no longer eligible for Leqembi?
So Leqembi was used in people with mild cognitive impairment and mild stage dementia in the study. So they would have to have the ability to perform their basic activities of daily living, which is self-care. So dressing independently, feeding, bathing, and toileting independently. That's what would qualify someone as having moderate stage. So they would be outside the window. Removing the amyloid plaque, may not work later on in the disease as the nerve cells have already died. And that's what was shown in previous studies. So this study only was done in people with really mild cognitive impairment and mild stage dementia.
You've got a couple more questions there,
Okay.
Dr. Natelson. Has research indicated that it's possible to have both early onset Alzheimer's and FTD?
I have not read anything. There's a lot of information. There's a lot of stuff going on right now about having more than two diseases at once. But it's more likely that person that actually happens much more often the older you get, because as we age, we have more risk factors for vascular disease and Alzheimer's, for example. The more likely thing is that somebody actually has that frontal variant, of Alzheimer's disease than having both. But the other thing is about frontotemporal dementia is that there aren't a lot of biomarkers. Like I said, all these tests we can do to prove that it's Alzheimer's disease, frontotemporal dementia is not there yet. So we don't really have as many ways of proving until they're gone and the autopsy is done, whether or not it's frontotemporal dementia, other than where the symptoms are located. And there's a certain pattern on the PET scan, the FDG PET Can you speak to hearing loss as a risk factor for developing Alzheimer's? Yes. So hearing loss, there's been several papers recently about hearing loss. We've known for a long time that hearing loss can lead to depression, withdrawal from regular activities in general, and all of those increase your risk of dementia. But now there's papers that actually prove that, that there's a direct link there, that hearing loss, is related to later development of cognitive impairment. So that brings up that it's worthwhile to talk about that ways to prevent dementia include, keeping yourself physically healthy. So exercise is the best medicine for your body in every way, and the brain is not, any different. The brain really needs you to have physical exercise in order to preserve some of the size and the speed and reduce your risk for developing Alzheimer's disease. Maintaining exercise physically and mentally. So mental exercise can be done by socializing, and that's how that relates to hearing loss. It's really hard to have engagement with other people with hearing loss. So the more isolated you become, the less you use your brain, and that increases your risk of dementia. So I know hearing aids are a pain, but it's worthwhile. And of course, that's going to take more work on getting hearing aids covered with policy, because hearing aids are really expensive, and especially if somebody already has cognitive impairment and they lose them, that certainly is a problem, but definitely something to be addressed.
So you've got another question. How risky is it to get DNA tested as far as insurance and pre-existing condition causes for APOE?
So I would not recommend getting it unless, you are going to get this drug. I don't think it's very helpful psychologically. And when you look at those other things that insurance companies might do with information in your medical file. So, somebody with a family history, just getting an APOE4 gene checked by their doctor just to see doesn't really provide you any benefit, because there's nothing to do about it. Now, in the AHEAD study, we are testing it for people that are in the research and providing that to the participant, but it's not going in your medical record. So you're a little bit less likely to have an insurance company pick up on that and deny you for, whatever long-term care insurance or disability insurance in the future. So until there's something that directly relates to, what are you going to do with that information, I wouldn't recommend that people get APOE tested. Now, if somebody's already got dementia or mild cognitive impairment, that's going to impact those things the same way, because they're already symptomatic. So the risk of getting that tested is lower. But it's definitely worth thinking about. I wouldn't just, get it without thinking through all of the scenarios.
Okay, well, we don't seem to have any additional questions that have been added. I want to thank you very much for how generous you've been with your time, Dr. Natelson. It's been really lovely to have these two opportunities to hear you present this information and reaching two different audiences. We will try to have a link and have this on our website, your talk. On our website, so others can view at their convenience. And again, I want to encourage you to participate in the golf tournament July 28th. If you're not a big golfer, there is always the Amazon gift card auction. And again, those are both of those fundraisers help raise money to fund student researchers at UAB. And part of our goal there is we want to entice young, brilliant students to establish careers in Alzheimer's disease research. So please join us in that effort, and hope to see you all on November 4th for our Alzheimer's walk. Thank you again, Dr. Natelson Love. We appreciate it, and we look forward to seeing everybody in the future. Bye-bye.
Thank you.